Hello everyone. So let us discuss a very interesting case which we very often face in our operating room. So this is a case of a 75 years old male with a well-controlled hypertension and a mild COPD, and he just got operated for Whipple surgery. Now the surgery was complex and complicated, so the total duration till which the surgery lasted was 5 hours. Now, the patient was maintained on total intravenous anesthesia with atrocurium infusion for neuromuscular block or neuromuscular paralysis. Now, just before completion of surgery, 30 minutes prior to the completion of surgery, the anesthesiologist gave the patient 10 milligram morphine, mostly for post-op analgesia. Now, after stopping all anesthetic agent, the 60-minute has elapsed. The patient is still not responding to command. The patient is not becoming conscious, not responding to any command. But patient is breathing spontaneously on ET tube and his vitals are stable. When he was investigated in ABG, most of the parameters were within normal range except PaCO2 was towards little higher side, 47 mm of Hg. So what is the diagnosis? Patient is after 60 minutes after the end of anesthesia, patient is not arousable, but patient is breathing spontaneously through the tracheal tube. So he is adequately reversed from neuromuscular blocking agent, but he is not arousable. So this is the diagnosis is delayed recovery from surgery and it has multiple causes. So diagnosis is delayed recovery after surgery. So to understand the causes of delayed recovery after surgery, we need to know what is adequate recovery after surgery. What do we mean by the term adequate recovery after surgery? Now, adequate recovery after surgery is the state of consciousness. It is the state of consciousness when the person awaken after surgery and become aware of their surrounding and identity. So if we ask the name, where you are, they give us proper answers. So this is what is defined as adequate recovery. Now, is there a fixed time to emerge from anesthesia? That within 10 minutes, within 5 minutes, the patient should become fully conscious and oriented? Actually, no. It is very variable. It can vary. In most of the studies, it has shown it can vary from, let's say, 5 minutes to 60 minutes, right? Most commonly, 10 to 15 minutes, most 80-90% of the patient becomes arousable. So there is no fixed time. So end of the surgery, there is no fixed time. There is no fixed time. Now, this is dependent on, the recovery is dependent on multiple factors, and it could be dependent on the type of anesthesia which we have given, the drugs which we have used, for the duration, for how long we have given, patient related factors, patient has some comorbidity which makes him more susceptible to the anesthesia, the type of surgery, some intra-op event which would have resulted in this delayed recovery if some intra-op cerebral event has happened, or metabolic derangement in intra-op period, hypoglycemia could be the cause, the temperature derangement could be the cause. So this has multiple reasons. So end of surgery, there is no fixed time. Now it could vary from 15 minutes to, let's say, 60 minutes. And if someone is not awakening even after 60 minutes, then that is arbitrarily defined as delayed awakening, right? After stopping the anesthesia, after 60 minutes also, if someone is not awakening, now it is something which is described as delayed awakening. So the awakening depends upon, as I said, multiple factors. It depends upon the type of anesthesia which we have given, the drug, the anesthetic agent which we have used, then for duration which we have used. Now, patient related factors, like if patient has undue susceptibility to the anesthetic agent, patient is very old, or patient has a metabolic derangement, patient has renal dysfunction, hepatic dysfunction, or has myasthenia gravis which makes him unduly more susceptible to the anesthetic agent, whatever. So patient related factors could be one of the reason. Then intra-op Intra-op derangements, intra-op complications, something happened intra-op. Now, intra-op, some, let's say, metabolic imbalance happened in the patient, like let's say intra-op patient temperature was not properly managed. So, patient has temperature dysregulation, then metabolic dysregulation, metabolic dysregulation. So these are some of the causes of delayed recovery. We would discuss the causes in, let's say, in detail. So what are the causes of delayed recovery? Under few headings we will discuss. The first would be the most common cause of the delayed recovery is residual effect of our anesthetic agent. The residual effect of the drug which we have used. So residual drug effect. Residual drug effect is one of the most common cause of delayed recovery. Then the second thing which we will discuss as the cause of delayed recovery is duration and type of anesthetic agent which we use. Then the nature of surgery. There are some positions which we make during surgery which can cause delayed recovery. So nature of surgery. Then respiratory failure happened in the patient, which could lead to hypercapnia and which could delay recovery. So respiratory failure, and as I said, metabolic and temperature dysregulation, and neurological causes. So these are the broad division in which I will discuss all the causes of delayed recovery. So small table. The common drug which can cause delayed recovery, which we use during anesthesia, is opioids, benzodiazepine, our sedative hypnotics that we have to use, the anesthetic agents, the volatile anesthetic agents, anticholinergic drug, neuromuscular blocking agent having prolonged effect. Then preoperative, some medication was taken by the patient like gabapentin, etc., which has resulted in, let's say, synergistic effect with our anesthetic agent and resulted in a delayed recovery. Then the causes like hypoxemia, hypercapnia, right, hypothermia, hypoglycemia, then electrolyte imbalance like hypernatremia, hypermagnesemia, calcemia, then thyroid derangement, hypothyroidism. The neurological causes like acute stroke, seizure, elevated intracranial pressure, hypoxic ischemic encephalopathy, hypoperfusion syndrome, which is a rare syndrome seen in carotid endarterectomy. So these are the broad causes of delayed recovery, and one by one we will discuss. So let us first discuss the residual effects, drug effects. So what are the patient in which we can suspect there is a residual drug effect? Now, too much drug has been given intra-op, let's say we gave somehow too much of the drug, or adequate amount of drug was given, but patient is unduly more sensitive. So too much drug, too much anesthetic agent given, too much drug may have been given, or patient is more susceptible, right? So what are the patient factors which make them more susceptible to the anesthetic agent? So we need to know some of the patient's factor which are making them more susceptible. One of the most important patient factors, extremes of age. So neonates, old age, we have to decrease our dosing. If you will give the dose of anesthetic agent in the same amount as you give in a normal adult, overdosing, there's a risk of an overdosing which would happen at the extremes of age. So first is extremes of age, like your neonates and old age, Then the second is body habitus. The patient is very frail and you have given the dose like any adequate individual, any normal individual. So in a frail patient, right, even if we give the drug according to total body weight, the risk of overdosing is there. So frailty, undue, increases the sensitivity to anesthesia. So frail, patient being frail. So frail body habitus. Okay. Then patient having some genetic variation making them more susceptible. Like for neuromuscular blocking agent, we know about succinylcholine apnea, which is seen in some of the patient who are, let's say, who have the gene or who have the enzyme gene which manufactures the enzyme pseudocholinesterase, not normal but makes it atypical. So in patient with genetic variation producing atypical pseudocholinesterase will be more sensitive to pseudocholinesterase, and these kind of examples are there with other drugs as well. So genetic variation, which is very difficult to detect pre-op. Then comorbidities. Now most of the drug are metabolized by liver and kidney. So in case of hepatic or renal failure, patient has decreased metabolism of the drug, and the byproduct of drug in some cases may accumulate and they can cause a delayed recovery. For example, in patient with renal dysfunction, the morphine which is metabolized by liver produces a metabolite morphine 3 gluconides, which is completely excreted through kidney. So in case of kidney dysfunction, the excretion is inadequate and let's say the amount of morphine 3 gluconide in the serum increases, and which has 1/3 of the same ability to cause respiratory depression as normal morphine. So again, patient will be unduly more sensitive to morphine, right? So comorbidities like your hepatic failure, hepatic and renal dysfunction, and this is mostly because of the delayed metabolism of the drug. Now, for example, another example, myasthenic patient. Now, myasthenic patient, they are more sensitive to non-depolarizing neuromuscular agent. So, they are more sensitive to non-depolarizing neuromuscular blocking agent. So, normally we give a lesser dose in them, and if I have given a normal dose, again, I would get a delayed effect of these neuromuscular blocking agent in these patients. So residual effect of drug. So that's why it is always said that you have to look your patient, and the dosing of the drug has to be decided according to the patient. Okay, the next is your duration and the type of anesthetic agent. So one by one, let us discuss the anesthetic agent which can cause delayed awakening. IV anesthetic agent, very commonly used during surgery. So if I have given a single bolus dose of IV anesthetic agent for induction, it will never cause a delayed recovery. But if I am giving TIVA, total intravenous anesthesia, and prolonged infusion, then there are drugs with a very high context sensitive half-life. Now, there are drugs which have a very, let's say, which are context sensitive. Context sensitive half-life is independent of their duration of infusion, like your remifentanil. There are drugs like propofol whose context sensitive time half-life does not change with increased duration of infusion. Even if we give for 2 hours or 6 hours, the recovery is the same. But there are drugs which have a slow recovery when their duration time is increased, like your fentanyl or your dexmedetomidine. So these drugs would give us a slow recovery if we use them for infusion during anesthesia. So intravenous anesthetic agent, as I said, single induction dose are unlikely to cause any delay. Those are unlikely to cause any delay in awakening, but accumulation would happen on infusion. Prolonged administration, that is prolonged administration. Now, prolonged administration carry risk of accumulation and delayed recovery. Now, this was the reason why your thiopentone was abandoned to be used as the maintenance agent for TIVA. Thiopentone, if we give prolonged infusion, it accumulates and takes a long time to go out of the body with a lot of residual effect. Propofol was one of the best drugs, which even with a prolonged duration time, showed a faster recovery because their context sensitive half-life is kind of does not change much on increasing the duration of the infusion. So it is not independent of the duration of infusion, but a very slight increase happens, right? So if I have to take my patient for a long surgery and I am giving IV anesthetic agent, I would preferably use agent like propofol. I would avoid the drugs through infusion like your midazolam or fentanyl or dexmedetomidine, because if for a very prolonged hours these drugs has been used, they have a high context sensitive half-life, and their residual effect may be seen. Okay, so I would rather preferably try to stop their infusion towards the end of surgery, right, so that they are excreted. So drug through infusion, drug when we are giving through infusion, we need to be aware of the context sensitivity half-life. So we need to be aware of context sensitive half-life, right? So we need to be aware of this context sensitive half-life. Okay. Now, inhalational anesthetic. Now, we are using the modern inhalational anesthetic like halothane, isoflurane, sevoflurane. Most of them gives a faster recovery. But the agents which are highly lipid soluble, they can accumulate and they can show a delayed recovery, like your halothane, your isoflurane, compared to sevo and desflurane. Now, desflurane has a very minimum lipid solubility and it has shown to give a fastest recovery in comparison with other inhalational anesthetic agent. So, inhalational anesthetic agent. Now, with inhalational anesthetic agents, there are two conditions in which emergence can be delayed. If towards the end of surgery, we are not giving a higher minute ventilation, then the recovery from inhalational would be slowed. And the second is, if we are using the inhalational agents with a higher lipid solubility, right, higher blood gas partition coefficient. So, emergence can be delayed. Emergence can be delayed due to alveolar hypoventilation. Alveolar hypoventilation. So, at recovery, what we need to do? We need to increase the fresh gas flow. We need to increase the minute ventilation of the patient. And if we discuss at the pharmacokinetic level of the drug, so at the pharmacokinetic level, the inhalational agent with a higher blood gas solubility, with the higher lipid solubility, have a slower recovery profile. So, inhalational agents with higher blood gas partition coefficient, and higher lipid solubility, they show a prolonged recovery time. They take more time to recover. Now, if I compare the commonest used agent, halothane, isoflurane, sevoflurane, desflurane. Now, halothane has blood gas partition coefficient 2.25, iso 1.3. Your sevoflurane has 0.63 and des has 0.42. So, definitely recovery would be fastest with desflurane, and otherwise also desflurane has lowest lipid solubility. So, this will give the fastest recovery. So, if my surgery has a anticipated very prolonged duration, I would preferably go for desflurane or sevoflurane for maintenance of anesthesia, since they would give faster recovery. Or towards the end, I would change to sevo and desflurane if I am using isoflurane in the patient for a faster recovery. Then opioids. Opioids are one of the main culprit for causing delayed recovery, particularly if we have given a very high dose of opioid in susceptible patient. Now, if I go back to my patient, the case which I discussed in the beginning, now my patient has a history of COPD and my patient was given 10 milligram of morphine 30 minutes prior to surgery. So both are pointing towards opioid as the cause of delayed recovery. Now COPD patients, they are highly susceptible to the opioids. They have a respiratory depression effect because of the opioid, and the morphine which was given 10 milligram. Now, but the patient's ventilation, in my case, patient was breathing spontaneously, only the consciousness was delayed. So there may be a possibility that the ventilation was not affected, or the CNS effect of the opioid was causing this delayed recovery. So opioid may contribute. Opioid may contribute in delayed recovery. May contribute in delayed recovery. Now, what could be the reason the opioid will produce delayed recovery? Prolonged sedation and respiratory depression are the two reasons. Prolonged sedation, they have a direct sedative effect, and respiratory depression. Respiratory depression. So these are the two reasons by which opioid can delay the recovery. So if we have given a higher dose of opioid, then we can use the direct reversal agent of opioid for reversing the effect. We can use naloxone. We can consider using naloxone if we have used a higher dose, and if patient was frail, and if patient has liver or kidney dysfunction, again the opioid overdose could be the cause of delayed recovery. Now fentanyl, we normally think it is a short acting agent compared to morphine. Yes, definitely it has a shorter duration of action, but the final metabolism and excretion of drug is not so short, especially if you have used it as infusion. So when we use fentanyl infusion, if in drop I have used fentanyl infusion, then it has a high context sensitive half-life. As and as the duration of the fentanyl infusion is increased, the context sensitive half-life is getting prolonged and prolonged. So fentanyl has a high context sensitive half time. So we have to keep it in mind. We can't think that fentanyl is a short acting one, and then if we stop fentanyl, there would be no residual effect. There is a possibility of residual effect, right? Okay, then benzodiazepine. Long acting benzodiazepine has been given. They can have a prolonged effect. Even the shorter acting benzodiazepine like midazolam can have a synergistic effect with our other anesthetic agent and can contribute in the delay recovery. So long acting used like your diazepam, your lorazepam, right? And they produce a synergistic effect. Synergistic effect, right? Now let's say if we give midazolam with fentanyl, they have an excellent synergistic effect, right? So we can consider it as contributing factor for delayed recovery. And if I'm thinking that the benzodiazepine overdose has happened or benzodiazepine susceptibility is more in this patient, then we can use the reversal agent of benzodiazepine, flumazenil. So we have a reversal agent for benzodiazepine, flumazenil. So we will discuss what is the dose of flumazenil in the management. Okay, then dexmedetomidine, an alpha-2 agonist. Now, dexmedetomidine is an excellent anesthesia adjuvant, but if we use for a prolonged duration of action, again it has a high context sensitive half-life. More the duration, slower would be the metabolism and excretion and can contribute in the residual effect. So dexmedetomidine, if used as infusion during anesthesia, has a higher context sensitive half time, so can contribute in delayed recovery. So what should we do that when I am using dexmedetomidine, and if my patient is not like patient in whom we are not very worried about the extubation, little bit about extubation response, I would stop dexmedetomidine infusion, right? Let's say 30 minutes prior to surgery if I'm using it for a long duration. Okay, neuromuscular blocking agent. Now, they never they don't have effect on central nervous system. So they do not contribute in delay recovery. But neuromuscular blocking agent would result a residual neuromuscular blockade, which would affect the respiration of the patient and which can cause hypoxia and hypercapnia. And this hypoxia and hypercapnia would contribute in delayed recovery, agitation and then delayed recovery in the patient. So these neuromuscular blocking agent, they never delay recovery. They never delay the delay consciousness or recovery, right? But because of the residual effect, residual neuromuscular block effect, the hypercapnia can happen and hypoxia can happen. So both of this can cause sedation. Now remember, if a patient has a pre-existing neurological deficit or pre-existing neuromuscular deficit, or patient seems unduly sensitive to neuromuscular blocking agent, the dose of the drug has to be decreased. And again, remember that when you are giving neuromuscular blocking agent with your inhalational anesthetic agent, right? Now, inhalational anesthetic agent potentiate the neuromuscular blocking agent. So, over the course of time, the dose of neuromuscular blocking agent should be decreased. Otherwise, definitely the residual effect, we'll see the problem of residual effect. So, it's surgeries of 5 hours. So, if at the same dose, I would go on giving the atrocurium infusion till the end of surgery, there is a chance that atrocurium would get accumulated and atrocurium, undull sensitivity with atrocurium would be seen in the patient, right? So, since we need to decrease the dose towards the end of surgery. Okay. And other thing is that for neuromuscular blocking agents, we have such a good monitors. We can use the neuromuscular monitor, we can use the quantitative monitoring, and we should have attained to a TOF more than 0.9 towards the end of surgery. Then there is some unusual causes like serotonin syndrome developed due to the multiple drugs and due to the drug the patient was taking before coming for surgery. Synergistic action happened and the serotonin level of the blood increased, and that's what is called serotonin syndrome. So patient who are on the drugs with serotonergic effect, like the selective serotonin reuptake inhibitors, right, or MAO inhibitors, they already are highly susceptible of increased serotonin level in the blood. And if we contribute by giving some agent which would contribute in this serotonin sparing effect, like your tramadol, right? So again, because of this, the serotonin syndrome can result. Okay, so metoclopramide, tramadol, they all can contribute. So patient who are on drugs with serotonergic effect, now most of your antipsychotic drugs, antidepressant drugs are with serotonergic effects, and receive during anesthesia drug with serotonin sparing effect, drug with serotonin sparing effect. So what are the drugs which the patient may be on? So for example, the patient may be on selective serotonin reuptake inhibitors, or patient may be on MAO inhibitors, and we have given them in a high dose metoclopramide, or we have given ondansetron, which we very commonly use during surgery, then for minimizing the post-op nausea and vomiting. Then we have given tramadol or pethidine for pain relief. Now they can also spare the serotonin, and this would result in serotonin syndrome. Now diagnosis is mostly clinical, seeing the clinical scenario. So diagnosis is mostly clinical. What happens? There is a change in the state of the consciousness of the patient. The patient becomes comatose, lethargy. But it is very difficult when the patient is getting recovered from anesthesia and these features are coming. So you have to have a high index of suspicion when this correlation between the drug may happen, right? So changes in the mental status, what we will see, changes in conscious state, patient may become comatose, become lethargic. Then autonomic dysfunction, autonomic dysfunction may be seen, right? And neuromuscular changes, hyperrigidity can be seen. So neuromuscular changes, hyperreflexia, rigidity, neuromuscular changes. So if these three are there, right? If these three are there, that is the the mood changes, the autonomic dysfunction, the neuromuscular junction dysfunction, then we can, in the background of these drugs being used in the patient, diagnose serotonin syndrome. And the management is mostly supportive. Management is mostly supportive.